let's talk about a topic that is absolutely essential for your microexams: infectious mononucleosis. This is all about the Epstein-Barr virus, or EBV, and trust me, you're gonna want to know this one cold. So let's dive right in.
So, you've all heard of the kissing disease, right? It's a catchy name, for sure. But here's the thing. The virus behind it, it's way more complicated and honestly way more interesting than just a simple nickname.
And this is the absolute core concept you need to grasp from the get-go. EBV is kind of two-faced. Yeah, it causes mono, that sore throat you've heard about, and this is a big but, it's also an oncogenic virus. We're talking a direct trigger for major human cancers like Burkitt's lymphoma and nasopharyngeal carcinoma. This Jekyll and Hyde personality, super high yield for your exams.
Okay, so here's our game plan. We'll start with the basics of EBV itself, then walk through how it takes over the body, what it looks like in a patient, how we nail the diagnosis, its connection to other diseases, and finally, how to manage it.
All right, first up, the basics. Let's get to know our culprit. You've got to understand the virus's structure because, honestly, everything else we talk about is built on this foundation. So check out its profile. First thing that should jump out at you, it's in the Herpesviridae family. Whenever you see Herpesviridae, I want one word to pop into your head: latency. Right? Just like its cousins, herpes simplex and chickenpox, EBV is here for life. It sets up a permanent latent infection. So for your exam flashcards, lock these 4 features in. Herpesviridae family, it's enveloped, it's got that icosahedral symmetry, and its genome is double-stranded DNA.
Okay, let's get into the good stuff: pathogenesis. How does this virus actually get in, and what's its master plan once it's inside? This is basically the story of a complete host takeover. So the infection plays out in 4 main steps. First, entry. It's transmitted through saliva, hence the kissing disease thing. Second, it finds its target. The virus hones in on B lymphocytes and pharyngeal cells by latching onto their CD21 receptors. Step 3 is the real kicker, the takeover. EBV doesn't just infect the B cells, it immortalizes them. It turns them into little rogue antibody factories, just pumping out all sorts of random antibodies. And finally, step 4 is the response. Your body's CD8 plus T cells see this chaos, and they launch a massive counterattack to destroy the infected B cells. And those big, angry T cells are exactly what we see on a blood smear. We call them atypical lymphocytes, and they are a dead giveaway for mono.
So you've got this massive war going on inside the body. Infected B cells versus our T-cell army. What does that actually look like when a patient walks into your clinic? Let's talk about the clinical signs. Okay, listen up, because this is pure exam gold. You have to know the classic monotriad: fever, pharyngitis or a really sore throat, and swollen neck glands, specifically posterior cervical lymphadenopathy. You might also see an enlarged liver and spleen, hepatosplenomegaly. This is super important because it's why you tell these patients no contact sports. We don't want a ruptured spleen. And here is a classic board question clue. Your patient gets a nasty rash after you give them ampicillin, thinking it was just strep throat. That rash is a huge pointer towards mono.
Now here's where the examiners love to trip people up. A patient comes in, fever, tired, swollen glands. It's screaming mono, right? Well, not so fast. It's not always that straightforward. Which brings us to the all-important differential diagnosis. You see, a bunch of other things can look like mono. We're talking cytomegalovirus or CMV, even early HIV. They cause what we call a mononucleosis-like syndrome. So how do you tell them apart? It all comes down to the labs. The key, and I mean the key, is the heterophile antibody test. If it's real deal EBV mono, that test will be positive. If it's one of the lookalikes, it'll be negative. That test is the absolute fork in the road for your diagnosis.
And that leads us perfectly into lab diagnosis. Honestly, if you're prepping for exams, this section is probably the most important one. So how do we prove it's EBV? Let's get into the forensic analysis.
Your first move, your step 1, is the screening test. And what are we looking for? You guessed it, those heterophile antibodies we just talked about. The classic test you might see mentioned is the Paul-Bunel test.
So what in the world are heterophile antibodies, really? Just think of them as the byproduct of those hijacked B cells. They're not actually targeting the EBV virus itself. Instead, they're just there, a sign that the B cells have gone wild. The classic test literally mixes the patient's blood serum with sheep red blood cells. And if these antibodies are present, they cause the sheep cells to clump together. That clumping or agglutination tells you it's a positive test. Okay,
But what if that screening test comes back negative, but you're still really suspicious? Or maybe you need to know when the infection happened. That's when you move to step 2, the confirmatory test. Now we're getting specific. We're going to look for antibodies made directly against EBV itself.
And this table, you need to burn this into your brain. This is your cheat sheet for EBV serology. The mnemonics are super simple and they work. Ready? VCA-IgM. The M is for this minute. It means the infection is acute, it's happening right now. VCA-IgG. The G is for gone. The infection is in the past. And finally, EBNA, the Epstein-Barr nuclear antigen. The E is for end. These antibodies show up at the very end, meaning it's a past infection. Seriously, memorize this. It will save you on exam day.
All right, remember how we said EBV has a dark side? It's not just about mono. Now we're going to look at the other major diseases linked to this virus, especially its role as a cancer-causing oncovirus. Okay, another super high-yield list for you. For malignancies, the big ones to associate with EBV are Burkitt's lymphoma and nasopharyngeal carcinoma. It's also linked to some Hodgkin's and non-Hodgkin's lymphomas. Now switch gears to immunocompromised patients. In them, you need to think of oral hairy leukoplakia, those white kind of hairy-looking patches on the side of the tongue, and other scary-sounding lymphoproliferative disorders. Okay, let's wrap this up. We know how to spot it, how to diagnose it, and we know its long-term risks. So let's close the case. How do we actually manage a patient with mono, and can we prevent it? When it comes to treatment, you have to know this one crucial distinction. For regular infectious mono, the treatment is, well, there isn't one. It's just supportive care, rest, fluids, painkillers. That's it. And here's the exam trap. Acyclovir does not work for mono. Say it with me. Acyclovir does not work for mono, but it is useful for oral hairy leukoplakia, which is also caused by EBV. See how tricky that is? They love asking about that, so don't fall for it. And what about prevention? It's pretty simple, really. You don't need to isolate patients because it takes pretty intimate, prolonged contact to spread. And the big one, there is currently no vaccine. Simple as that. So if there's no vaccine, why is this thing everywhere? Well, look at this number. Over 90%. That's how many adults worldwide have been infected with EBV. It's just incredibly common. And this quote right here tells you exactly why. The main source of the virus isn't people who are sick with mono right now. Nope. It's the massive pool of people, that 90%, who already had it, have no symptoms, and are just walking around, occasionally shedding the virus in their saliva. That makes trying to contain it pretty much impossible. So we'll leave you with this final thought. EBV is just a fascinating and kind of scary reminder that a super common virus, one that most people get without even knowing it, can immortalize our cells and is linked to multiple cancers. It really makes you wonder, right? What other everyday germs might be hiding these kinds of long-term risks? It's definitely something to think about. All right, that's our deep dive on EBV. Hit the books, and we'll catch you on the next one.